here literally is due to causes which are genetic. So you name the genetic diseases that you see sitting in your OPDs are so diverse, and successive governments have done nothing about it, and there is no national health policy, and allocation of budget is so dismal. Now, Children's Hospital sees a large number of patients. It's one of the biggest, largest hospitals in the globe. And as I said to you, I'm a gastroenterologist, hepatologist, and I got involved because children with either lysosomal storage disorders or inborn errors, they would have some degree of either hepatomegaly, splenomegaly, something, or alteration in allergies, and they come to our unit. And most of them, about 10-15 years ago, they didn't have a diagnosis because we didn't have a lab in Pakistan. Now, we'll have a collaboration with our German colleagues, and soon the good news is the Children's Hospital, the University of Child Health, will have its own metabolic unit in place for the entire Punjab to have the test done. So that will be good news very soon. Now, we have completed, this I should have put in as 20,000 tests, more than that. So what are inborn errors? These are genetic disorders that disrupt your biochemical processes in the body, and when they by either altering an enzyme activity or cellular transport, or unfortunately sometimes the mitochondrial bioenergetics. Till 1942, we didn't know much about them, till somebody in Germany first talked about PPA, and now we know more than 600. But remember, you only need to know the common ones in your country. So when you have an inborn error, there is a block at some point in your normal metabolic pathway. So you have an alteration in the DNA which might code for an enzyme, a receptor, a transport vehicle, a membrane pump, a structural element. So what do you suspect? You're sitting in your OPD or in your emergency room. If there is a history of death of siblings, or there's more than one child like that in the family, particularly with the neurological ones, don't label them as cerebral palsy. Or if symptoms started when you change the diet, or he's had recurrent admissions with either vomiting or sepsis-like illness, or somebody noticed acidosis. Children who are seniors, who have developmental delay, regression of milestones, or somebody noticed one or low blood sugar. Unusual odor the parents will pick up. Parents are consanguineous. Or you have unexplained deaths in first or second degree relatives. The sister's child died and they don't know why. So you might have acute signs in child, or you might have chronic. So every time, don't think of an inborn error as something acute, that they will always come to you with acidosis and low blood sugar. Yes, that's one of the ways where organic acidemias will come. So there's acute signs. But then if you have chronic signs, vomiting, failure to thrive, what about lysinuric protein intolerance, which come to you with just vomiting and failure to thrive, developmental delay and regression, a bit of liver, cardiomyopathy, spastic diplegia. So in the brain presentation, in an acute way, you might have an encephalopathy with or without metabolic acidosis, or you might have acute liver disease, as I said. So they might have neonatal cholestasis, like the citrate deficiency, or hepatic failure, like tyrosinemia, hypoglycemia. You might have paroxysmal disorders which will have dysmorphic features. Can we close the door? Because there's a lot of disturbance from the door. You might have cardiac disease, like in fatty acid oxidation defect. You will have cot deaths, or children dying in their sleep in fatty acid oxidation defects. Splenomegaly in LSTs. Predominantly neurological symptoms in aminoacidopathies, as I said, or some fatty acid oxidation defect. But today, we'll be focusing on the common ones. The organic acidemias, disorders in amino acids. So chunk them in your mind like that. Organic acidemia, disorders in amino acids, hyperammonemia, so these are disorders of urea cycle, disorders of fatty acid oxidation. Then you come to the difficult topic of lactosidosis and mitochondrial disease. This is a panacea of everything. We're not talking about the other groups, but just to I put it in there for you, because when you read about inborn errors, you will see these headings as well. Now, a 2-month-old this is an actual patient that I was assessing. A 2-month-old is brought to the emergency with history of vomiting, lethargy, altered sensorium, respiratory distress. Vomiting was so significant that baby was investigated for suspected pyloric stenosis. And a lot of metabolic errors are like that. Whether it's and sometimes your congenital adrenal hyperplasia is like that. There's a past history of one sick death at 8 months when nobody knew why the baby died. Parents were cousins. You're called in because the ABG shows metabolic acidosis. So what further investigations now, standing there with a ear physician, would you like to order? How will you manage this baby? And what is the most likely diagnosis? So, the following tests you must obtain: complete blood count. Frequently you see neutropenias, thrombocytopenias in your common organic acidemias, like propionic and methylmalonic acidemia are the top of the list. Almost 80% of the organic acidemia that you will see will fall in Pakistan in these two categories. So you will ask for arterial blood gas, somebody did that. Electrolytes, you will ask for blood glucose before, and you ask it from a separate vein. And remember, some of these organic acidemias will have a rebound hyperglycemia. So don't be surprised if the initial sugar was 40 and now it is 220. Plasma ammonia you will ask. You will always ask for a lactate, LFTs, save the urine for urinary ketones and also for urine reducing substances. Ask for a serum uric acid because it might be low in some metabolic errors. Now for this child, the CBC showed pancytopenia. The plasma ammonia came really high. The metabolic acidosis was there. YCAR was 3, pH was 7.01, blood sugar of 50 and urine ketones 3 plus. So what is the diagnosis? A lot of people sitting here would pick up that this is, at least you would put it in the chunk of, it's an organic acidemia. And what did I say? The commonest organic acidemia is in Pakistan. So it's not difficult. It's methylmalonic and propionic, and our data shows that. And we have also given that data to health department to develop the newborn screening program in the future. So standing there, I will show you this slide again and again. We do a blood gas. It shows metabolic acidosis with raised anion gap or no acidosis. So if you have an acidosis, you would like to obtain lactate. You have an elevated lactate versus a normal lactate. The lactate will not be highly elevated in your regular organic acidemias or in your MSUDs, your aminoacidopathy, some of them which are chunked as organic acidemias. So if it is lactate is not high in the blood, you think of disorders which will come back to you later. So stay on the right side for now. If the urinary ketones are highly positive or versus no positive, you think of the disorders on the bottom right side and we'll take you through them. And as I said, these are the common ones. So I chunked the top two. Now, this third one will give you a clue by having fall of hair, some skin manifestations. So the mother says, skin में कुछ eczema है. Skin का eczema और बालों का change फिलहाल कुछ इंजुरिया में भी है, but वो organic acidosis के साथ नहीं आएंगे. So that's the thing. Isovaleric and glutaric acid, they will not have any skin changes, but they are less common than they are. Now what will be then? You think now you have an inborn error of metabolism. The second tier investigations will come in. So you need to do these tests in a targeted manner in a developing country, but not a crash and course approach. So in organic acidemias, don't forget to do your urinary organic acids. Sometimes I see a patient and somebody has asked for quantitative plasma amino acids, but no organic acids. Now we don't do SL carnitine profiles in Pakistan, but these are very important tests which might have in future. Then also we will ask for quantitative analysis of amino acids. And in some of these organic acidemias, you will have high level of some of the amino acids, particularly like in propionic acidemia, you will have, I will come to that and show you the report as well. And the last of it is genetic testing. So you can diagnose a metabolic error without genetic testing, but you will need that for confirmation and future prenatal. Now, we'll come to the next part of the slide later on that you must always ask for a lactate and pyruvate because the ratio of that is important and the level of it is important. Ask for urinary uric acid, it is available in our farm. So you go along in an algorithmic manner. You can have some enzyme assays like the GALT assay and a biotinidase assay. Now this patient's quantitative amino acid came back and the glycine was high. Hyperglycemic ectotic acidosis is propionic acidemia until proved otherwise. So this patient who had high ammonia, we got the gene tested as well, and then so therapy was started somewhere where, and what happened? What happened? What is this? What is this that you see? There's a huge rash on the body. The child is on treatment, but he comes back like this to you. Well, this is the problem. Many physicians in Pakistan will solely prescribe basic P. But this is totally protein free. And children will be referred back to us because they have hyperbilirubinemia, the protein rashes, and you cannot ever put a child on only basic P. So we started him on proper treatment. This is the same child, low protein diet, high carb and normal fat, avoid prolonged fasting, gave the baby carnitine and the benzoate for the ammonia. And remember, this is PPA, so we will give metronidazole 1 week per month. And we give a special formula which is methionine, valine, free and low in isoleucine. This will allow for a greater protein allowance. But if you don't have that formula, you calculate your protein and give a normal formula in the food. You calculate the protein in the food, but please don't ever just give basic P. So what are the principles of treatment of a suspected organic acidemia? Reduce or eliminate protein intake in 6-day remission for the 2 days that he's there. Good hydration, prevent catabolism, treat acidosis, give your carnitine, give your benzoate, give your cofactors. You do not know what he has. Does he have MMA, PPA, biotinidase? So you will start the biotin, you will start the B12. And remember, don't make the mistake of giving B12 orally only. In the B12 responsive, you need parenteral, so they can give it like insulin in the skin as well. You give the thiamine for MS. So you give a cocktail initially, the coenzyme for the lactobacillus patient, and you give them a 6-day management. Some tips. In a child with acidosis, who's doing this? There is massive ketonuria, but there's severe neurological manifestation. Some of the biggest, these kids with MSUD, they arch like anything and they have seizures. And this is a prototype of a maple syrup urine disease patients. They will have rashes and then in methylmalonic you will have a very bad candida rash. They can have myoclonic jerks and hair loss in acidosis, the thing of biotinidase. And if you have acidosis in a neonate before he is fed, he has fructose 1,6 or a GST type 1. Okay, remember there's only 2 diagnoses. If you have a neonate who got acidotic before you ever fed him milk. Now this is an 8-month-old who came to us with rash, acidosis, he was well before 3 months, and hair loss. Okay, tell me what it is? Yes, so biotinidase. This is a treatable metabolic disease, and you treat them with biotins 5 milligram to 10, and sometimes you might require higher, up to 30 even, but that's less treatment. It's a misdiagnosis, and this is the genetic testing for that. So the organic acidemia, as we said, the ones we saw in Children's Hospital, you can see that the biggest bar there is MMA and PA. But we have a fair chunk of biotinidase. I won't go into details of the rest, but I want you to take home some important messages only. It's very important to recognize the type of methylmalonic that you have. That your methylmalonic can be treated in Pakistan. Some types which are not responsive to B12 are there, like this one, not responsive. They will consistently show bad neurological recovery. They cannot even feed after a few months. It's despite aggressive management, they won't make it. But then don't miss out on these kind. This little girl came with lethargy and bizarre behavior and ataxic gait. She was referred to us as Rett syndrome because she had been doing well before. So remember, all your organic acidemias can be intermittent type also. So you have the severe neonatal version, you have the milder version, or you have the intermittent version. So don't miss out on them. She rides in a wheelchair, she turned out to have MMA, and there she is doing so well on therapy. This is the picture that she sent. Again, there is a big diversity in the genotype, phenotype of propionic acidemia. You might have a child who you are doing everything, like the one on the right, and he doesn't seem to be doing that well. This is a severe genotype. And there is a 12-year-old of our patient, he goes to school. So So sometimes you might end up counseling them wrongly initially and say, oh, it's a very tough disorder, you might not make it. It might not be normal, but then you have to figure out that over time. But neonatal presentation may be bad. So this one is the missed one in Pakistan. So I would like to say, this is a treatable neurometabolic disorder. And we want this to be part of the neonatal screening program. This kid came to us with delayed speech, delayed language development, probably neurology, our neuro departments in developmental, they might have referred this patient to us. Dystonia, feeding difficulties, T2 hyperintense basal, when you see basal ganglion lesions on the MRI, think of metabolic. And this poor kid actually, he had a treatable neurometabolic, which is glutaric aciduria. Our patients picked up in time are doing so well versus those who have terrible dystonia and are bedridden. So pick them out from your cases. And when your metabolic tests are misleading, you will ask us for genetics. So this patient kept coming with acidosis, ketones, and hyperglycemia. We kept thinking proteinic acidemia, and we tried to treat her, but it ultimately turned out that she had a different disorder. So, but this was a disorder, the SCOT1 disease, that this was treatable by just having frequent meals with large amounts of carbs. But this should be your prototype of management. But in many cases, if you do the prototype management of avoiding fasting, avoiding high protein, and avoiding stress, you can do well. Now, I want to highlight one disorder in this lactocidemia only. And if you go back to this one, if you have metabolic acidosis and you have increased lactate with a normal lactate to pyruvate ratio, and you have hypoglycemia, think of GST and fructose 1,6. Because this 5-year-old boy was coming to us with metabolic acidosis, positive ketones, because remember, patients who will have a problem with, in this disorder with the carbs, will have and try to burn their fat in their ketones. Ammonia normal, elevated lactate, abnormal LFTs during episode of acidosis. And first he was diagnosed somewhere as GST because he had a massive liver, triglycerides were high, uric acid they behave like that, but immediately afterwards they get well, their liver regresses, they're normal kids. So this is a totally treatable one, fructose 1,6 biphosphate. You will get normal labs in this, but in the urine organic acid you might see a glycerol B. Otherwise, majority of the times your labs from the metabolic tests are normal. And this is a very common disorder in Pakistan. Autosomal recessive fructose 1,6 biphosphate. And then the card will skip over some of these details, but again go back to your algorithm. Remember where your fatty acid oxidation defects fall. That you have acidosis and your ketones are absent, but you have a patient who is acidotic with hypoglycemia with altered LFTs, but because he cannot burn the fat, his ketones are absent. They require longer period of fasting in their organic acidemias to actually go into it, but they suddenly die. They're lying in their crib, they have no alternative fuel engine to work. Not like the glycogen storages, not like your organic acidemias, but the alternate fuel supply is there. The fatty acid oxidation on will suddenly go poof, they die. So you can read this very quickly, jump over it. The treatment is avoidance of fasting and avoidance of long chain fatty. Means you avoid these regular fats and supplement them with MCT, and you prevent fat soluble vitamin deficiency. And this is, so we'll skip over some of these cases in the interest of time. And this patient, so patient can come with an encephalopathy, and the encephalopathy was disproportionate to the liver insult. So this kid did not have albumin which was low, did not have a deranged PT, but was an encephalopathy, and he had similar episodes in a peripheral hospital. And liver tests were always deranged during. Remember to think about metabolic disease, because your metabolic disease, this was an autosomal recessive carnitine acylcarnitine transferase deficiency. These are treatable disorders. So, and lastly, just one thing, phenylketonuria is there, but is not very common. So frequently I'm asked, in most cases, they are referred as query PKU. Remember, in your child who has lost hair or has dermatitis, think first of biotinidase, but it is microcephalic and has no acidosis and is having seizures, yes, PKU is a possibility. But thalassemia is one of your commonest immunoacidopathies. They might come to you with bad liver disease, with kidney disease, but then patients who are in treatment do very well. Remember I told you one of the limb carried you to no acidosis but high ammonia. You cannot think of urea cycle disorders if you have acidosis, because they will have alkalosis, because ammonia will make you breathe faster and you blow out your CO2 and you have kind of an alkalotic blood picture. But with acidosis, you can have propionic acidemia, methylmalonic, glycinuric, fatty acid oxidation, hepatic dysfunction will have but isolated hyperammonemia is in urea cycle defects. And you must remember that their therapy is not only very tough, you have to tailor the diet very appropriately, and they come to you very shortly after birth, or sometimes at a later stage when they start increasing the protein amount. And so their treatment will not only be on low protein diet, they will need ammonia scavengers for life, like sodium benzoate, which is available to us, but you will also have to supplement with arginine or citrulline. Don't forget to do that. You might need dialysis in their very crisis states. And this is one of our triple H's who is a physician holder, is a urea cycle defect. Sometimes we have families where all children died, and I have to pick out the diagnosis from the parents. And these were parents who lost everybody. They were married for 8 years, and we did the carrier testing. And so you need prenatal in these patients. So get their genetics before they get pregnant. And the last two slides are on the biggest challenge of having a normal person. So your genetic counseling is so important to prevent genetic disease. The quest for normal has, as Anjum showed you, multiple children with the same disorder. These are patients with the same disease, more than one child. So prenatal is important. So with the help of partners, we set up the colonic sampling. This is done in a sister hospital. We have carried out more than almost 200 CBSs in the past 3 years. And we use special RPMR tubes. And so basically, if you have a mother who has lost children, or you have one metabolic test saying MMA, you cannot send her to me at 12 weeks for a CBS unless I have a genetic test. Because if I do her carrier testing on her child's genetics, it will take me 4 to 6 weeks. And then it will be too late to do CBS. So plan these pregnancies, get their genetic testing before the next pregnancy, and we will get the CBS at 12 weeks of pregnancy. So in summary, I have to rush over some slides, but I'm sure there are some take-home messages that you have. This inborn errors are very common. There is an urgent need for newborn screening programs, and it will happen. We are negotiating it. It's very poorly taught at undergrad as well as postgrad. Very few centers to diagnose. Trained dietitians are absent. We are doing dietary advice. We are not trained to do that. Limited availability of diagnostic tests. Patients may die or have permanent handicap. Special nutrition is expensive. We need to identify centers of excellence for diagnosis and treatment of these disorders. And do not hesitate to pick up the phone and discuss cases with each other. We need to develop the database which we have at the Children's Hospital, and we need to expand on it with your cooperation in other hospitals. Development of prenatal testing facilities and introduction of a fellowship in metabolic and genetic diseases, so that you have a full-time trained human resource. And I think a lot of the centers can push CPSP for such a fellowship. So we always have hope and light at the end of the tunnel. Thank you so much.